Good afternoon, ladies and gentlemen. My name is Mohsen Sharifi, and it's a pleasure to be presenting at NCVH Digital Education Series. The topic of discussion for today is managing shock and hemodynamic support in pulmonary embolism. This is a very interesting topic, but hopefully patients would not have to get to that stage, because once they do, the horse is out of the barn and the prognosis is dismal. Some background on pulmonary embolism: over 100,000 cases of mortality is recorded in the US alone. This figure is probably higher, in the range of 150,000 to 200,000. And the sad thing is that these are preventable causes. Without treatment, the 90-day mortality is close to 60% if it is massive PE, and around 15% if it is submassive PE. Like everything else, there's a spectrum of disease severity for pulmonary embolism. On one side of the spectrum, there is stability of hemodynamics. However, there is progressive deterioration manifested by RV dysfunction, right ventricular failure, which can lead to shock, and that can become irreversible very rapidly, and death can subsequently ensue. Some of these slides are from the recent European Society of Cardiology guidelines, which were published last year, and they are very valuable, and I would recommend the viewers to read this document. The pathophysiology starts with an increase in RV afterload secondary to pulmonary embolism. This leads to RV dilatation, increase in RV wall tension, neurohormonal activation, increase in right ventricular oxygen demand, subsequent right ventricular ischemia, reduction in contractility, reduction in cardiac output on the right side, and then it would lead to changes on the left ventricle as well. There is septal bulge with increase in RV size, leading to depression of cardiac output and resulting in hypotension, which would lead to a reduction in coronary perfusion of the right ventricle, leading to obstructive shock and subsequently death. Now, if you look at the data from Mass General Hospital on those patients who qualify for some form of advanced treatment, meaning not just anticoagulation, more than that, which mostly is thrombolysis, you would see that the traditional thought process that only 5% of the patients would qualify no longer holds. This is from the PERT data that they came to the conclusion that about 65 to 70% of the patients can benefit from some form of advanced treatment. This is a typical presentation of somebody with massive pulmonary embolism. This is the right side of the heart. You can see the right ventricle. The dimension is over 2 times that of the left ventricle, and massive enlargement in the right atrial size. Obviously, you do not want to treat these patients in the traditional way. Right ventricular failure is the determinant of death, and it is affected by 3 components, like this left side: the preload, the afterload, and the contractility. Vasopressors play a role in modifying all these parameters. So do inotropes, pumps, and administration of fluids. One has to be very careful with administration of fluids, as we will get to it shortly. In the category of severe PE or massive PE leading to shock and instability, there is also a spectrum in itself. On one hand of the spectrum, there is cardiac arrest and the need for cardiopulmonary resuscitation, which almost uniformly carries a dismal prognosis. Somewhere in the middle is obstructive shock. And according to ESC guidelines, that's defined as a systolic blood pressure of less than 90, or the necessity for administration of vasopressors to keep the blood pressure above 90, plus, and the plus is important, evidence of end organ hypoperfusion, such as altered mental status, clammy skin, increased serum lactate levels. The better part of the spectrum is persistent hypotension with systolic blood pressure less than 90, or a systolic blood pressure drop of over 40 millimeters of mercury, which lasts longer than 15 minutes and is not caused by a reversible cause such as an arrhythmia, hypovolemia, or sepsis. Now, this is a graph I've made, which is important, and we'll come to this later in the talk. This is in reference to survival of patients post-cardiac arrest due to PE. So it is a unique category of patients who have had cardiac arrest. And as you can see, the survival is very dismal, very rapidly from the onset of the event. Now, you can see deliberately I have not put the survival probability because really nobody knows that. But from anecdotal data and our own experience, we believe that if you are able to do something for this category of patients within the first 15 minutes, you can make a change. Otherwise, no matter what you do, you put them on ECMO, you put them on thrombolysis, use catheter-based interventions. Once this period is lost, the outcome would be very poor. As far as fluid administration, one has to be very careful because in RV dysfunction, there's a chance that intravenous fluid loading may actually worsen RV failure. The increase in the venous return can cause further RV dilatation, RV ischemia, and subsequently lead to a septal shift and further decrease the LV and diastolic volume. This has actually appeared in the ESC guidelines. The volume not to exceed is about 500 milliliters given over 15 to 30 minutes. It should be considered in patients who have normal to low central venous pressures due to, for example, hypovolemia of some other source. However, the caveat is that it can overdistend the right ventricle and worsen the ventricular interdependence and reduce cardiac output. As far as vasopressors and inotropes, norepinephrine is now regarded as the first choice. And if the patient is unresponsive, dopamine can be added. Dopamine is not a vasopressor, it's an inotrope. Norepinephrine is both an alpha and beta blocker and hence is suited very well to treat these kind of patients. There is a limited role for phenylephrine and pure alpha agonists. If I said blocker, I meant agonist. It increases the pulmonary vascular resistance, and vasodilators should be avoided. There is a good role for bedside echo or point of care echo because a lot of these patients are not stable and you anticipate that they can decompensate if they are going to get a VQ scan or a CT angiogram. So the ER physician or the attending physician can do a quick assessment of the heart function, the right-sided chambers, and make a decision whether PE is probable or not. In the guidelines, the starting dose for norepinephrine is 0.2 microgram per kilogram per minute, which can further be increased to 1 microgram per kilogram per minute. Dobutamine is started at 2 micrograms per kilogram per minute and can be increased to 20 micrograms per kilogram per minute. Now, this is a condensation of the changes that have occurred in the 2019 guidelines. First of all, unfractionated heparin should be initiated as soon as there is suspicion for PE. You don't have to wait for diagnosis. You can start it and modify your treatment. That approach, by the way, in this era of COVID crisis with high frequency of venous thromboembolic disease is also mirrored. In other words, you get anticoagulation going on before you have the diagnosis, and then you have time to sort out things later. Systemic thrombolytic therapy is recommended for high-risk PE patients, and that's a class 1. We'll get to these with level of evidence B later on. Interestingly, surgical embolectomy is now grade 1, class 1, level of evidence C, for patients with high risk for PE in whom thrombolysis is contraindicated or has failed. So this is important. Catheter-based interventions are actually given a lower significance, and they are class 2A as compared to surgical pulmonary embolectomy. Norepinephrine and or dobutamine are class 2A. And interestingly, ECMO, extracorporeal membrane oxygenation devices, can be considered in combination with surgical embolectomy or catheter-directed interventions, and they are now given a class 2B level of evidence C. If you look at the US guidelines, we are still behind, and I anticipate that in the near future, these guidelines would also change. If you look at the American College of Chest Physicians, both in 2012 and 2016, class 2A indication is given for massive pulmonary embolism, and class 2B indication for submassive embolism when there is evidence of RV dysfunction and myocardial necrosis. If you look at the American Heart Association guidelines, came out in 2011, a grade 2C is given for massive PE and a similar grade for submassive PE. But again, I'm sure these things would change. Now, if you compare the ESC guidelines from 2014 to 2019, rescue thrombolysis has moved from 2A to class 1. Surgical embolectomy has moved from 2B to 2A. D-dimer measurement now has a role to be considered specifically during pregnancy and in the post-mortem period from 2B to 2A, and even for asymptomatic PE survivors who are deemed to be at high risk for development of chronic pulmonary hypertension or CTEPH. At one time, it was not indicated. Now it's a class 2B to evaluate those patients. As far as PE with shock and hypotension, again, anticoagulation should be initiated as soon as the suspicion rises. Thrombolytic therapy is given 1B class indication, surgical pulmonary embolectomy 1C, and catheter-based interventions as 2A with level of evidence C. Now, in my opinion, and again, this is my opinion, full dose thrombolysis, which is defined as the FDA-approved 100 milligrams of TPA, is very effective. However, it is not safe. And that is why we brought the concept of safe dose or half dose thrombolysis, as I would be alluding to shortly. The dreaded complication of thrombolysis is intracerebral hemorrhage. If you look at all comers who receive TPA for one reason or the other, be it for myocardial infarction, stroke, and so forth, intracerebral hemorrhage has been reported at about 1% to 6%. For PE, it runs about 2 to 3%. Now, there are other devices, catheter-based devices that have been used and are being used, but these have not entered the guidelines in the US. And with the exception of the ECMO that we will be talking about shortly. Catheter-based interventions includes AngioVac, AngioJet, the Inari device, which is a suction system without necessarily administering thrombolysis. So this may be of use in select cases, the Penumbra and the ECO system. We have more information about the ECO system, and it has been numerously reported. It is catheter-facilitated thrombolysis by ultrasound. The catheter is placed in the pulmonary arteries, and thrombolytic therapy is given at low dose. And the theory is that these vibrations can break the clot easier. Now, I have serious doubts about the role of the ultrasound. I think the TPA is what does the trick and cures the patient. This is a patient who has two of these catheters because usually these are bilateral pulmonary embolisms. And in my opinion, it defies logic because, as you can see, the convergence of flow is in the lungs. So anywhere you administer TPA, be it from a capillary in the finger, a central line in the toes, ultimately the flow goes into the lungs. And you do not need a plastic catheter to deliver that TPA there. You can use God's catheter, which is the vein, to deliver that TPA. However, you should lower the dose. The lungs are therefore exquisitely sensitive to thrombolysis because they receive the entire cardiac output and hence the entire amounts of those TPA molecules. You don't see that in the lower extremity venous circulation. You don't see it in the heart, which receives 5% of the cardiac output, or the brain, which receives 15% of the cardiac output. We introduced this concept of low safe dose thrombolysis in the MUPPET trial, moderate pulmonary embolism treated with thrombolysis. This was used for submassive PE. However, we are using the same protocol now for massive PE. In other words, the treatment is similar. Now, we did compare half-dose thrombolysis with the ECOS catheter in a retrospective fashion. It was recently published, well, in 2019, and it involved 47 patients in the catheter-directed group and 50 patients in safe-dose thrombolysis group. In both groups, there was significant reduction in PA systolic pressure and in the RV-LV ratio. As far as death, bleeding, transfusion, there was no significant difference, although death was more seen in the ultrasound facilitated group because of the complications associated inherently with the procedure. In one of them, unfortunately, the patient was discharged home, didn't realize he's bleeding. By the time he came back to the ER, he couldn't be revived and unfortunately passed. But statistically, there is no difference. Duration of hospitalization is lower with safe dose thrombolysis. Delivery of drugs is standard 50 milligrams here. It's about half as much with the catheter-directed group. And duration of drug delivery is 2 hours for the half-dose group, whereas it's about 15 hours for the catheter-directed group. There was another study, I believe this was from Cleveland Clinic, and they retrospectively analyzed 221 patients. 32 of them had some form of catheter-directed thrombolysis, and they came to the conclusion that catheter-directed thrombolysis does not improve hospital outcomes despite adjustment for PE severity. And in fact, it was associated with significant increase in overall and ICU length of stay. Well, it's obvious that if you're putting a catheter in somebody's lungs and giving TPA, they should be in the intensive care unit. A randomized trial in the lower extremities for acute iliofemoral DVT compared catheter-directed thrombolysis with ultrasound, the ECOS catheter, with passive thrombolysis, and they came to the conclusion that there was no difference. Now, we have other mechanical assist devices that have been used and are continuing to be used, but the data is limited. Most of the data are related to the ECMO. Impella has been used, and so has the tandem heart. The ECMO is usually used in conjunction with other treatments. Anticoagulation alone has been used, although thrombolysis, percutaneous intervention, and surgical embolectomy are also being used in combination with ECMO. The VA form of ECMO is the one which is mostly used, and it's from the femoral artery to the femoral vein circuit. There has been there have been a few reports on limited VV usage of ECMO. The question comes, well, these patients have already failed thrombolysis. Now you're putting large bore catheters in them. Yes, that's an issue, but you have to be cautious and probably use ultrasound for guidance. And before the device is removed, the RV function can be quickly reevaluated with a bedside echo. This diagram shows the VA and a variant of the VA, which is VVA ECMO. This is predominantly what is used. Here you have the VV ECMO, which is used. And in general, the patients would benefit from this form of approach. Now, there is a growing body of evidence showing that ECMO can indeed be useful in this setting. But again, the numbers are limited. Al-Bawardi published his data on 13 patients. All of these patients had cardiac arrest, and they all had PERT activation. They had RV hypokinesia and enlargement. The age was around 50 years. 8 of these patients had additional systemic thrombolysis, 3 had catheter-directed thrombolysis, and 4 had surgical thrombectomy. The mean ECMO duration was 5.5 days. 30-day mortality, however, was 31%, and 1-year mortality was 54%. They were fully anticoagulated, and 35% of these patients had in-hospital bleeding. The Impella device, which is chiefly used for the left side, there's a variant of it which was approved in 2017 called the Impella RP. A part of it is placed in the pulmonary artery and part of it in the right atrium or in the upper venous circulation. The advantages is its relative simplicity. It only uses the venous approach, and it does generate a flow of around 5 liters per minute. The disadvantage is that it only bypasses the failing right ventricle. It does not oxygenate. So imagine that you are giving a high flow of 5 liters per minute to an area that more distally is associated with extensive clot burden. So you're trying to plow through all that thrombotic burden. So the results may not be as good. And this is the appearance of the RP Impella in association with 2 ECOS catheters. Indeed, the FDA came out with a warning in 2019. In February 2019, they witnessed an increased rate of mortality in patients receiving the Impella RP system, and the letter went out to the healthcare providers. This was different. The post-marketing data was different than the data before the approval went into effect. 4 of the 23 patients who were analyzed, that's over 17% of them, just over 17%, made it to 30-day survival endpoint. In other words, 83% of these patients were dead. And so really no benefit came from this device, and maybe some harm was imparted because of the reasons I just mentioned. The tandem heart, which is usually used for the left side, can be used on the right side as well. It does provide RA and PA flow, and it does provide oxygenation. Downside is placed through the IJ, and it doesn't support the LV if it's done that way. This is a traditional left-sided tandem heart transeptal cannula. Catheter is placed in the left atrium, and the other return is into the femoral artery. What it does when it's used for the left side, it does reduce the workload of the heart. You're looking at the pressure volume curves. You can see the area under the curve is the workload, and it is significantly decreased with this device. Now, the cardiac power is a parameter that is used for predicting mortality in shock patients, and it was actually used in the shock trial. It is the product of the mean arterial pressure expressed in millimeters of mercury times the cardiac output in liters per minute divided by this constant number 451. So let's say somebody's arterial pressure is 100 and the cardiac output is maintained at 5 liters. That's 500 divided by 451, which is over 1, and that puts the outcome at a very reasonable survival rate. However, if it is below 1 and clearly below 0.6, the mortality can be as high as 70% or more. Surgical embolectomy has gained momentum, but it's not done in all centers. So there are certain locations, institutions that are suited to do this procedure, and not all cardiovascular surgeons should be doing this. Massive or submassive PE with contraindication to lysis is the prime indication. Acute PE with right atrial thrombus or thrombus in transition is the other indication. However, if there's thrombus only in the right side of the heart, I've used safe dose thrombolysis with excellent outcome. If you look at all comers, it is performed only in 1% of PE patients who have had massive PE and were in cardiogenic shock. And this is based on 2 large PE registries. In 2013, there was around 27% inpatient mortality. In 2018, in those patients who were treated with ECMO and surgical embolectomy, it was around 29%. Now, there is an outlier here, Dr. Pathophysiology from University of Maryland. They published their data from 2010 to 2017. So this is a single institution. And within 7 years, they had 57 patients only. 29 of these patients were embolectomy alone, and they formed a historical control. 27 underwent a protocol-directed treatment with administration of ECMO, and 14 of these had embolectomy. The 1-year survival was very good, actually, even with embolectomy alone, and in the historical control group of 73%, versus 96%, which is outstanding, in the protocol-directed ECMO plus embolectomy. There was no ECMO embolectomy deaths, and however, one should recognize that not every surgeon is capable of getting these results. In the broader context, in-hospital mortality nowadays, as it stands, is 12% in experienced centers, 32% if PE is preceded by cardiac arrest. Again, going back to the guidelines of European Society for Cardiology, surgical pulmonary embolectomy is now recommended for patients with high-risk PE in whom thrombolysis is contraindicated or has failed. And that's given a class 1 level of evidence C, and it comes before catheter-based interventions. The ECMO has entered the guidelines here. We don't have it in US guidelines, but in ESC guidelines, it may be considered in combination with surgical embolectomy or catheter-directed treatments in PE with refractory circulatory collapse or cardiac arrest. Again, class 2B. Going back to my slide initially, which doesn't have the actual survival probability here, we believe that this 15 minutes is very important. And you can make a change if it is something is done in this part of the curve. And we had our limited study called the PPET study. Initially, we had a MOPET study, then we had the PPET study. PPET stands for Pulseless Electrical Activity in Pulmonary Embolism treated with thrombolysis. It was published in an emergency medicine journal. And We looked at 23 patients who had cardiopulmonary arrest due to massive PE. Now, this was not possible PE, it was definitive PE. And we administered immediately, as soon as we got the call from the ER, 50 milligrams of TPA in 1 minute. It was given on average 6.5 minutes since encounter. And 21 out of the 23 patients had hospital survival, and 85% of the total patients survived at 22 months. So it is again very important that if somebody collapses and needs resuscitation due to PE, something to be done immediately in the first few minutes. Probably this is more critical than acute MI that you have a window for 90 minutes. So in conclusion, there is a very poor outcome of pulmonary embolism if there is cardiac arrest or pulseless electrical activity, with the exception, anecdotal exception, unless treatment is given within 15 minutes of treatment. Every effort should be done to prevent PE because it is a preventable disease. ECMO and other mechanical assist devices are encouraging tools, but they should not be regarded as a cure for patients in this category who uniformly have a dismal outcome. Every effort has to be, again, done to prevent such occurrences. I thank you for your attention.